dacryocystorhinostomy. So endoscopic endonasal approach is to correct the nasolacrimal duct system was described by way back in 1800 by Caldwell. So West and later during the procedure. So this approach was not popular because of technical limitations which included visualizations and availability of instruments for soft tissues and bone removal. To depopularized external dacryocystorhinostomy, and then this procedure was in vogue for quite some time. The introduction of rigid nasal endoscopy kindled interest in endonasal approach to the lacrimal sac. The first dacryocystectomy was performed by Celsus in 50 AD. McDonough was the first to perform endonasal dacryocystorhinostomy in 1989. Anatomy of the lacrimal apparatus. Knowledge of lacrimal apparatus is must before embarking on endonasal lacrimal sac procedures. The lacrimal sac consists of a superior and inferior puncta at the medial end of the upper and the lower eyelids. And these two drain into the upper and the lower canaliculi. So these two join to form the common canaliculus. This zone is known as the upper canaliculus system. The common canaliculus in turn leads into the lacrimal sac. The sac is about 12 to 15 millimeter long. It eventually narrows and leads into the lacrimal duct, which drains into the inferior meatus of the nose. The nasolacrimal duct is about 18 millimeters long. The sac and the duct comprise of the lower lacrimal system. The junction between the common canaliculus and the lacrimal sac is guarded by the valve of Rosenwiller. This valve prevents the reflux. The nasal end of the nasolacrimal duct at the level of the inferior meatus is guarded by Hasner's valve. Supraorbital valve. You can see. Physiology of lacrimal apparatus. Tears move from the eye into the nose through a mechanism known as lacrimal pump. Movements of the lids cause the puncta to close against each other, pushing tears into the lacrimal sac. Tears accumulating in the sac are further pushed down into the nasolacrimal duct when the eyes open because of relative negative pressure caused by the lacrimal lake. Location of the lacrimal sac. A good intranasal landmark or location of the lacrimal sac is the anterior portion of the middle turbinate. The sac lies just lateral to it. The lacrimal fossa is bounded by the anterior lacrimal crest, which consists of frontal process of the maxillary bone. The posterior lacrimal crest is made up of lacrimal bone itself. You can see the lacrimal sac diagrammatically, the shadow, the maxillary line, and then the uncinate. The middle turbinate also seen. Internasal landmark for locating the sac. The maxillary line is the mucosal projection along the lateral wall that serves as the landmark for endoscopic, sinus, and orbital procedures. Indications for primary endoscopic dacryocystorhinostomy. In the management of tearing associated with primary acquired nasolacrimal duct obstruction, infection of the lacrimal sac associated with primary acquired nasolacrimal duct obstruction, nasolacrimal duct obstruction secondary to specific inflammatory or infiltrative disorders. The level of obstruction should be distal to the junction of the lacrimal sac and the duct. In the management of lacrimal duct injuries associated with sinus surgeries, contraindications for this procedure are presence of a firm indurated mass above the level of the medial canthus, bloody epiphora, presence of bony destructions as seen in radiological films. Pseudoepiphora is essentially reflex tearing. The main gland overcompensates secretions because of lack of secretions from minor salivary glands along the lid margin. History and patient Examination history of unilateral or bilateral tearing must be sought. Unilateral tearing mostly indicates obstructive pathology in nature of discharge must also be sought, that is, whether clear or purulent. Environmental factors such as allergies should be elicited. Medications history are important as well as previous history of trauma or surgery. On physical examination, palpate the region of the nasolacrimal sac to see if we can elicit any reflex from the puncta. Eyelid should be carefully examined for evidence of excessive laxity. Punctum should be examined for evidence of obstruction or inflammation. Excessively lax eyelid should cause FE4R. TCR may not help these diseases. The canaliculus must be probed using a Bowman's membrane. A hard obstruction could be caused by bone or calculi. A soft obstruction should be caused by obstruction by a soft tissue. Nasolacrimal duct can be further examined by irrigating the duct with a syringe. Jones test should be performed to identify the level of obstruction. The test includes passing a fluorescent into the conjunctival sac and then visualizing the fluorescent in the nose. If you do not see the dye, after 5 minutes you can see it. And then you can perform a secondary test by irrigating the duct. If after irrigating the duct no dye is found in the nose, then the dye may never really reach the lacrimal sac to begin with. Obstruction is likely proximal if you see the dye in your irrigate, and then dye did reach the nasolacrimal sac, and it is likely to be obstruction is distal. You can also take the help of CT scan to visualize the nasolacrimal duct. So, done under local or general anesthesia, the procedure. So it is visualizing the sac internally with guide, and then the illuminator can be used through the puncta. The mucosal incision is given at the elevation lateral wall of the mucosa, the fria savillata. It is then the Carison's bone punch is used and then nibbled from the maxillary line till anteriorly. The shadow of the lacrimal sac is visualized, and the bone removal is done with a Carison punch 2 mm or 3 mm, or with the long shank endo drill with a cutting burr till the axilla of the middle turbinate, above the axilla of the middle turbinate. Some advice, and then the sac is visualized and then incised, and the anterior and posterior lip of the sac are visualized and reflected onto the anterior and posterior walls of the opening. Advantages of some advice: using mitomycin at the lips of the sac to reduce its closure. Advantages of endoscopic DCR: there is no external scar, the lacrimal pump system is preserved, any concomitant intranasal pathology causing FE4 can be addressed, lacrimal sac mucosa is preserved. It is advantageous to access the lacrimal sac through the nasal cavity. By this intranasal approach, incision over the face is avoided. The lacrimal pump mechanism is preserved. The procedure is very safe and can be performed under local anesthesia.